So I will start by introducing myself. I'm Michelle Shepard. I am an assistant professor of pediatrics. I work both at the UVM College of Medicine, Larner College of Medicine, as well as University of Vermont Medical Center. And I also use she, her pronouns, and am a middle-aged white woman with short brown hair and a black and white dress on today. Today I am going to cover neonatal abstinence syndrome. So we can go to the next slide. So several objectives today that are slightly edited, but I wanted to cover both neonatal abstinence syndrome and the more commonly used nomenclature now, which is neonatal opioid withdrawal syndrome, or NOWS. We want to talk briefly about pharmacologic and non-pharmacologic interventions for neonatal abstinence syndrome. I want everybody to have an idea of Vermont-specific protocols around CARA and CAPTA, which are federal legislation that addresses neonatal abstinence syndrome. And also just briefly wanted to add in some experience and stigma related to neonatal abstinence syndrome. Next slide, please. So some brief definitions. So first and foremost, neonatal abstinence syndrome is actually a constellation of symptoms. And this can occur in newborns exposed to multiple different substances during pregnancy, including opioids, which is what we think of most commonly, but also benzodiazepines and barbiturates exposures. So this is a more broad term of constellation of symptoms you'll see with several different medication exposures. Neonatal opioid withdrawal syndrome, or NOWS, is a much more specific constellation of symptoms that occurs in newborns exposed to opioids during pregnancy. Now, this can include opioids that are prescription for pain, opioids. This can be heroin or fentanyl. These can be other medications that are used for opioid use disorder. And so any of the opioid class can cause this constellation of symptoms. Next slide. So when we talk about signs and symptoms of neonatal opioid withdrawal syndrome, we're really talking about a number of different things. So first and foremost, the things people will notice most commonly are things like increased stiffness, increased moral reflexes, tremors or jitters, high-pitched cries. One neurologic thing that people often fear, but is extremely, extremely rare, are seizures. As far as gastrointestinal issues, there's difficulty feeding, excessive suck, difficulty gaining weight. Here we go. And also we see some autonomic instability, so elevated temperature, sweating, rapid breathing, things like frequent yawning, sneezing, congestion, and other signs and symptoms we often see are excoriation, particularly diaper rash, and sleep disruption. So a lot of different symptoms. Next slide, please. So the timeline of onset really depends on which opioid. And so, as I mentioned, there are multiple different ways that infants can be exposed to opioids in pregnancy. The classes of short-acting opioids include both prescription medications, such as your commonly thought of Percocet, Vicodin, oxycodone, morphine, codeine, many different medications. But those, as well as the short-acting illicit substances such as heroin and fentanyl, will often have symptom onset within 24 hours of the last dose used by the pregnant person. So these are symptoms that are going to develop rapidly and generally will show up similarly to the period of symptom onset for the person who is using the opioids. So these opioids, again, if you've been on them for a long period of time and you suddenly discontinue use, you will, as an adult or as an infant, have a constellation of symptoms related to that. Now, your long-acting opioid antagonists, such as those we use in therapies to treat opioid use disorder, such as buprenorphine, which is also known as Subutex, buprenorphine naloxone, which is also known as Suboxone, or methadone, these are long-acting medications and take much longer to move off the receptors in the brain and body. So the onset of symptoms really doesn't begin until after 24 hours and more commonly between 48 and 72 hours. And that's also can be seen as late as 5 days, very rarely, but that also speaks to why infants are monitored for 4 days or more for signs and symptoms of withdrawal related to those long-acting opioid antagonists. Next slide, please. So really important things to keep in mind, and this is important as we go forward and as we have shared communication with pregnant people, is really about 50% of infants with known exposure to opioids during pregnancy will develop clinically significant signs of NAS or NOWS. So it's not every baby that develops symptoms, and of those babies that develop symptoms, many of them are very minimal. So another important thing is that symptom severity is not, underline, related to the amount of opioid used. So the medication dose does not predict whether the infant will have symptoms or how severe those symptoms will be. So it is not recommended to have people during the end of their pregnancy try to wean down on the doses of the medication. NAS and NOWS symptoms are treatable. These are treatable symptoms, and they resolve with time. And then again, many infants with symptoms of NAS or NOWS are treated with non-pharmacologic measures. So we're supporting infants through these few days of symptoms. Most infants here at UVM Medical Center do not require any medication treatments. And of those who do, we often are only using 1 or 2 doses of medication at this time. So 80% of infants that do develop signs, and only half of them develop with signs and symptoms, 80% of those infants are not going to require anything other than supportive care. Next slide. There are many non-pharmacologic treatments, okay? So one of the most important non-pharmacologic treatment is breastfeeding. And this is really important. There are many mixed messages that pregnant people get around breastfeeding and medications and whether or not they pass into breast milk. There are very few true contraindications to breastfeeding. So breastfeeding or breast milk is one of the best strategies, along with skin to skin, parental rooming in. So really key to talk to the family in advance and know that we're expecting them to stay and care for their infant for 4 or more days. And so important for them to also have people that they can come and stay with the infant when parents need a break, as anyone would after 5 days in the hospital. We also recommend gentle handling, low lights, keeping the environment quiet, swaddling. There's investigations around aromatherapy, music therapy, massage. Some institutions are looking at acupressure. But at the end of the day, the most important thing that we can do is really help that baby be a baby by offering them lots of feeds and rooming in and being skin to skin with their parents. Next slide. So if an infant does need treatment of medication for their symptoms of NOWS, there are several different medications that can be used. Generally, we're treating opioid withdrawal with opioids. So at some institutions, they use morphine as that treatment of choice. Here at UVM Medical Center, we continue to use methadone. And there are some other places around the country that have started using buprenorphine as the treatment of opioid withdrawal syndromes. Tincture of opium was an old choice. They no longer use that. Rarely, infants will need a second medication if they're having very severe signs and symptoms of withdrawal, and those can be things like clonidine or phenobarbital. I really wanted to kind of highlight here on the side, though, the duration of treatment is very variable. Okay, so this could be 1 to 3 doses of a medication, or it could require several weeks of treatment and weaning. And there's no way, again, to predict that until we have the infant and we're monitoring for their signs and symptoms. The location of treatment is also variable amongst different hospitals. So some hospitals provide medication in the room with the parent and allow rooming in, while other places, such as currently here at UVM Medical Center, require transfer to the NICU for initiation of medication therapy. Next slide. So one of the things I spend a lot of time helping parents do is prepare to come to the hospital and prepare for the transition home. So lots of appointments have to happen and lots of referrals are done on discharge for infants with signs and symptoms of NAS or NOWS. So they're going to need to see their primary care provider or pediatrician. We're going to recommend nurse home visiting, early intervention. We want the parents to be taken care of and attend their postpartum appointments. And then if there are additional community supports, WIC, Reach Up, all these other, that's a lot of appointments. And so helping people to be prepared and to plan for this in advance is really helpful. Next slide, please. So I did want to talk really kind of briefly and broadly about the importance of all of us understanding how the federal laws around substance use in pregnancy affect us here in Vermont. So really important that we have a brief understanding of CAPTA, which is the Child Abuse Prevention and Treatment Act, initially initiated in 1974 and has gone through a few different amendments. The most recent amendment is called CARA, or the Comprehensive Addiction and Recovery Act, and this came about in 2016. This really formalized the plan of safe care, which we're going to talk about briefly. But this is something that's required for infants that are affected by substance use or withdrawal during pregnancy or fetal alcohol spectrum disorder. Next slide. So there are 4 requirements, breaking this down, around substance use in pregnancy, so CARA and CAPTA. The first and foremost is we're required to identify infants that are affected. We are then required to notify Child Protective Services in our state. We need to develop a plan of safe care. And then the Child Protective Services agency of the state has to report annual data back to the National Children's Bureau. The goal here and the overall goal of CARA is to address the needs of infants that are affected by substance abuse, withdrawal, or fetal alcohol spectrum disorder by supporting them and their family. Next slide, please. In Vermont, we took a very different approach to CARA and CAPTA legislation than many other states. So the goal here was to focus really on continuing to attract opioid-dependent pregnant people into treatment of opioid use disorder rather than pushing them away, right? So the fear of DCF involvement is enough to keep many people from seeking their own treatment. And so we did not want that to happen here in Vermont. In Vermont, we defined 2 separate pathways, one for DCF reporting and one for CAPTA notifications, which would allow us to minimize the involvement of DCF when there are no child safety concerns. We also updated the DCF policy to not accept reports when the sole concern was use of marijuana during pregnancy, because unfortunately federal law does require us to report the number of infants that are exposed to marijuana, but in our state we did not want DCF involvement for that sole reason. We also developed a de-identified CAPTA notification pathway. So what this is allowing us to do is report the numbers of infants to the Federal Children's Bureau while maintaining family privacy because it has absolutely no information about the family. Next slide, please. So just to make it very clear, a CAPTA notification is a pathway that we developed in Vermont. This is a de-identified tracking form that's sent to DCF for reporting to the Children's Bureau. These are completed only currently under the following 4 situations. When a parent is using medications for opioid use disorder during pregnancy, when a parent is using prescribed opioids for pain during pregnancy, or prescribed benzodiazepines for anxiety during pregnancy, or any use of marijuana in pregnancy after the first trimester. I think it got cut off here, but DCF reports are made when there is use of an illegal or illicit substance in the 3rd trimester, when there are signs of symptoms that are concerning for fetal alcohol spectrum disorder, or if a pregnant person is using non-prescribed or misusing prescribed medications during the 3rd trimester. Next slide, please. So just so everybody has an idea, this is what a CAPTA notification form looks like. This is the new version of the CAPTA notification form that we developed in 2021. There are 2 ways that these can be submitted. One is via secure fax line and two is via secure email line. No cover sheets required. And what we did was make it very, very clear that there are very few times that you need to make a report during pregnancy to DCF. And so those are all here again, but also the reminders that if you are doing a captain notification form, you also should be doing a plan of safe care. Next slide. So this is the entirety of the information that is submitted to DCF. There is a checkbox for what the reason for the notification. So again, those prescribed medications, use of marijuana, and then we're tracking of additional substances, including alcohol and nicotine. And then finally, the 3 questions that are required that we report to the Federal Children's Bureau is whether or not that plan of safe care was sent to the infant's primary care provider, whether or not the pregnant individual received additional new referrals or was already receiving referrals for, sorry, I'm going to try to fit this to my window so I can see it a little better. There we go. Was already receiving services prior to delivery. So at the very bottom here, I just want everyone to know this is so important. No information, no names, no birth date, no address, no phone numbers, no nothing. A unique hospital record identifier, which is the 4 digits of the hospital coding. So basically, if you're from UVM, it's UVM. But the only things that remain are the last 4 digits of the hospital medical record number. And that is so you don't duplicate your own submissions. But otherwise, this is it. This is all that goes to DCF. There's nothing on here, no parent, no child information, nothing. Next slide, please. So that transitions us to what a plan of safe care is. And again, this is something that was required by federal law, but there was absolutely no guidance given of what had to be in the plan of safe care. And so each state was allowed to develop their own pathway and their own information. In Vermont, we decided that the Vermont Plan of Safe Care needed to be created with the pregnant individual themselves, as well as involved caregivers. Our goal was to have it started during the pregnancy. It must be completed prior to birth hospital discharge. So what we wanted on the plan of safe care is a documentation of supports and strengths, in addition to areas of some needed supports and referrals. So it really just helps remind people which areas families may benefit from if they don't already have those referrals in place. It is shared with the infant's primary care provider after birth and given to the caregiver. It is not sent to DCF, however. This is a piece of paper that is for the family and for the infant's caregivers. It is not for DCF. The only time DCF has plans of safe care is when they've developed one because there was child safety concerns on their side. Next slide, please. So this is what the Vermont Newborn Plan of Safe Care looks like. Again, we have a list on the top of the indication for the plan of safe care. This does include some information about the parent and the infant and the primary care provider, and that is why it is important that this is not shared with DCF, because it does have some identifying information on it. Next slide, please. This is the second half. I really wanted to blow it up. I hate when nobody can read tiny little print. So I want you to see that the very first thing on here are a list of current supports as well as strengths and goals for that family. And then we have a list of services, supports, and referrals. So basically the services and supports that are in place, you'll get a status of currently receiving. And then you can have a new referral placed from this information. We left the box in the middle to allow the hospital team to put any information like a phone number or who the family could follow up with. So if they are discharged from the hospital and they get home and they're like, oh man, who was supposed to call us from nurse home visiting? Who was supposed to call us from CIS? We can put the information there for families to follow up on. Next slide, please. And these are just the additional supports. So these are caregiver supports that we recommend. You know, what we opted to put here is it's really, really important for the medications for addiction treatment or medication for opioid use disorder, as well as mental health, substance use, and community and panel team membership, that we wanted to make sure that people know that that needs to be protected, and the families should not put contact information there if they don't want that shared with the infant's pediatrician. Of course, you know, other types of things that we often recommend, so parenting support, smoking cessation, reach up, housing, childcare resources, any of those things, if they were a new referral place, can allow the pediatrician to help follow up on those if the family needs assistance with that. Next slide, please. And so I just wanted everyone to know that the Plan of Safe Care is available online. It's much easier to find now than it had been previously. So there are frequently asked questions now, also on CAPTA notifications, the Vermont Plan of Safe Care, marijuana use in pregnancy, but there's also a Plan of Safe Care handout for families. And it explains what the Plan of Safe Care is, what a DCF or CAPTA notification is, and why their information is protected and not shared with DCF unless there are child safety concerns. So this is the Plan of Safe Care website. This is the Plan of Safe Care handout. And so this is what it looks like, the one that you can hand to families, and tells you why it's being done, what information is on it, and who gets to see it. Next slide, please. So I think that the first and foremost thing we can do is prepare families both before the baby is born and on discharge home what to expect. So during that hospitalization after the birth of the baby, parents should expect that the birth hospital staff are going to support them in caring for their baby, assist them and encourage them with breastfeeding. They're going to monitor for signs and symptoms of NAS or NOWS, and they're going to use specific tools such as what we use here at UVM, the Eat, Sleep, Console Care tool, with the underline again here that babies need to be monitored for at least 96 hours. This is not 24-hour vaginal delivery discharge home. They do need to be monitored for that longer time period, as again, if you are on Suboxone, methadone, or buprenorphine, it can take up to 72 hours to begin to see the signs and symptoms of withdrawal. And then before discharge, the family will complete the Vermont Plan of Safe Care with hospital staff, and each hospital identifies different staff. That can be care management, it can be social work, it can be bedside nurses, but the Plan of Safe Care will be done with the family and sent to the infant's primary care provider at the discharge. Next slide, please. So really important that we are supporting caregivers, okay? And there's good evidence around this. I did include the references for these at the end, but we want collaborative, non-judgmental care for the mother-infant dyad, and as well as the other supportive caregivers. There is good evidence that symptoms of neonatal abstinence or neonatal opioid withdrawal symptoms can make infants harder to care for. They're harder to console. And those caregivers need additional support and positive reinforcement from home health-based services, in-house based services, their pediatricians, and everybody. And really important that there's a transition to home plan, and that helps people feel empowered and prepared for discharge. Next slide, please. It's also important that we encourage families to continue to support themselves in their recovery. It can be very difficult with a newborn at home to continue to make this a priority. So I think it's just really important that we continue to support pregnant and parenting individuals to reach out. And I think peer-based support services are just so key. We know that's key for anyone that's had a baby to get, home visiting in the home and to get peer-based support. But It's a really important thing to support recovery, and recovery from opioid use disorder is no different than that. So having recovery coaches or peer mentors with lived experience can really help decrease stigma and the feelings of blame and shame. And so ideally, if we're able to connect people prior to delivery, that's amazing. If not, if we can, help people connect after delivery. Things are definitely better now with COVID starting to be a little bit in the rearview mirror, that we're having a little more access to in-person services, but looking for local services such as the Rocking Horse Circle of Support, other local peer recovery centers, really, really important. Next slide, please. And reducing stigma around NAS is also really important. And again, the reminder being that only half of infants that are exposed to opioids during pregnancy are going to develop clinically significant signs. But families really worry about this. Many parents have experienced withdrawal symptoms themselves, and they're very unpleasant. And nobody wants their infants to have to go through that. So people may be afraid to disclose drug use during pregnancy, or even to disclose to their partner if they're on therapy. So it's really important that we continue to decrease that stigma around getting treatment and continuing treatment during pregnancy. And the idea is really that we really need to continue with the public awareness campaigns, right? That opioid use disorder, like all substance use disorders, are a medical condition, and that treatment and recovery supports are there, but we have to have access to them, and we have to reduce the stigma to people so that they can continue to access those supports. Next slide, please. So this is always my thing. So I always say early communication and clear messaging is key. So we want to combat parental fear with facts. We want to reinforce that medications for opioid use disorder is the best treatment for opioid use disorder in pregnancy, and it is safe. It is safe for the parent. It is safe for the infant. Stopping during pregnancy puts both the pregnant person and the baby at risk. In Vermont, really important, DCF does not get involved. If the only concern is marijuana use, or if a parent is using prescribed medications during pregnancy, and that includes benzos, it includes opioids, and that use of methadone, buprenorphine, Suboxone during pregnancy does not automatically trigger DCF involvement. And I think people are afraid of that. And I think the more we can say, hey, this is something you can do for yourself, and healthy parents make healthy infants. And DCF is not going to be involved if there's no child safety concerns. I always want to empower pregnant people, always to ask more questions. Ask what it's going to be like. Ask what the baby's signs and symptoms might look like. How long will it last? How do we treat it? And again, just making sure that we're fighting stigma with truth, right? So the truth is, we're here to help you. The truth is, we're going to help your baby get through this, and that you're the best treatment for your baby. Next slide, please. So where can you get more information? Please feel free to just email me directly. I'm always happy to answer questions. My email is here. It's michelle.shepherd@med.uvm.edu. There's also a secure email line that's just for questions about the plan of safe care and CAPTA notifications, as well as all the information on the DCF Plan of Safe Care website. Next slide, please. And then I included some references, and that should probably be the end of my slides.
This is Jesse. Yes, Michelle, that's the end of the slides. And sorry for some of the formatting problems there.
Do I have a couple of minutes to answer? I saw a couple of questions had come in that are pretty specific.
Yeah, this is Jesse. There's a couple of messages that have come in through chat that we'd love for you to address. So let me go back up. So one of them is, many of the families we work with deliver in New Hampshire, Is the plan of safe care utilized by New Hampshire providers or other states, or is it just for Vermont?
That's a great question. Every state has to have their own plan of safe care. So anyone that delivers in New Hampshire will have a New Hampshire plan of safe care completed, and it still should be sent to their providers, whether they live in or practice in Vermont or New Hampshire. New York is still working out their process. So their process in New York is not as consistent, but both Vermont and New Hampshire have very established plan of safe care processes. However, I will say that there is a difference in each state, whether or not they automatically involve Child Protective Services. So New York takes a very different approach to that than Vermont and New Hampshire.
Thank you. And Michelle, there was an earlier question that asked, as a pediatrician, if DCF asked, would you be able to confirm if there was a plan of safe care in place, understanding that you can't share the plan?
So if we receive the plan of safe care from the hospital at hospital discharge, generally when DCF calls us, we are able to provide information such as any concerns about not making scheduled appointments, or if there's any other concerns. So if the question was a plan of safe care sent to you at hospital discharge, of course I could answer yes it was, or no it was not.
So it looks like a couple more questions are coming through. Michelle, can you see those? I don't want to slow things down.
All right,
I'm happy to read them.
Okay. All right, so Kim writes in, it seems that in the Brattleboro area, when mom is in treatment, DCF is notified and visits while in the hospital. So generally, if a family is in medication for opioid use disorder treatment, but is unable to maintain, I hate the word stability, but stability in treatment. So if there was actual use of heroin, fentanyl, or non-prescribed medications during the third trimester, then DCF often is notified. There are other reasons that DCF gets involved. So certainly if there were child safety concerns with a prior infant, or if there are additional child safety concerns that are not related to their MAT or MAOUD treatment. But generally, I would say of all the infants here, probably only about 1 or 2 out of 10 has DCF involvement for all of the infants that are born to parents that are on maintenance therapy. And then Mary writes in, all parents, bio and foster, are interested in the latest research on long-term effect of NOWS and NAS. I can tell you that there is a lot of information out there about long-term effects of NOWS and NAS, and the general, if you read the papers very closely, the important thing is whether they control or not for Medicaid enrollment. So there are many other factors that affect the long-term development. So again, adverse childhood experiences. This is one, if your family is actively using substances and not in a recovery program, that would be one, but there are multiple other things that contribute to that. And so in a lot of the bigger studies that go back and look, like meta-analyses, the bigger factor looking at things like ADHD, behavioral problems, or developmental delays, if you compare to the general population, there may be some differences, but if you control for Medicaid population, that often disappears. And then Amber writes in, are there any times a mother on MAT, Suboxone in particular, should not breastfeed? The answer is there are only 3 conditions that would make a mom not be able to breastfeed. So a medication that's you're not able to breastfeed on would be basically for cancer treatment, for if someone was having their thyroid radiated, if they have active HIV, that's not on highly effective antiretroviral treatment, Or if someone continues to use illicit IV substances. And that's really because they're just at higher risk of infection as well as exposure to those high doses. But anyone on Suboxone, methadone, or buprenorphine should be encouraged to breastfeed if they are actively engaged in their recovery and are no longer using IV substances. And I think that's all the questions, but I'm happy to share all the resources. I'm part of the revision team, and we are undergoing revisions again in the next year. And so we'll update our language from MAT to MOUD as that nomenclature has changed, as well as if anyone has any recommendations around additions to the plan of safe care or ways that we can update it and make it more user friendly, please feel free to email me.